both. Intracranial regulation. If you have book number, the 10th edition, it is chapter 41. Okay. I was reading your book last night, and
What's the title of the chapter?
neurological emergency. I guess I could carry both books.
No.
I guess I could carry both. It gets a little heavy though. When you carry both.
They are.
So, but for those of you, because this should be 10th edition, is why I use the 10th edition book. And your chapters are the same pretty much. I just don't know which chapter it is in the 9th edition. So neurological emergencies is what we're going to focus on today. We do have a couple missing, not sure why. Anybody know?
Stuck in traffic from
St. Albans?
Yeah, but I think that she just got the here. But that's what she was saying.
Oh, okay. And anybody know about the other one? No. I think it's the two up here, right?
My guess is Abby's getting tested because she was out yesterday.
Okay. Well, we'll go ahead and get started. So we're going to talk about intracranial regulation today. And we're going to talk about some seizures. And we're going to talk about stroke. Okay? Stroke is normally covered in your fourth semester, I think, a little more in depth. But we are going to touch on it because we do see a lot of stroke patients. Okay? So, there's a lot of information on these slides. It is in your book. However, I do suggest that you go back and read your chapter 41 for neurological disorders. Okay? So our objectives, we're going to be able to define and describe the concept. We're going to notice risk factors that place these individuals at risk for intracranial regulation problems. We're going to recognize when an individual has problems with intracranial regulation. And we're going to provide appropriate nursing and collaborative interventions to optimize their recovery. Okay? This recovery is not short by any means. These need long-term therapy once they have this damage. So, go back to your anatomy and physiology. The brain. The brain does a lot of stuff. Okay? So it's just a review of your anatomy. So, intracranial regulation, your pressure is increased by these three components, okay? Brain tissue, blood, and CSF, your cerebral spinal fluid, okay? Your normal intracranial pressure should be between 5 and 15. The sum of these three pressures, the sum of the pressure exerted by these three volumes. If ICP reaches 20, it requires immediate attention, immediate treatment. So we're gonna talk a little bit about this, and you know, a brain injury is any damage that can be caused by an external mechanical force, or it can be caused by inside the brain, right? Swelling, pressure like that. So a force that is applied by a blow to the head is considered a direct injury. Okay? And a force applied to another body part with a rebound effect on the brain, which would cause swelling and things like that in the brain, is also known as indirect injury. Okay? So our cerebral spinal fluid, it acts as a shock absorber. It supplies nutrients to the brain. It is formed in the ventricles. And it's kind of similar to like plasma, but minus any proteins that are there. Okay? The role that it plays is it delivers our glucose. Hypoglycemia is widespread neuronal injury. Okay? Hyper is worsened. It is ischemia, injury, increased. Our cerebral blood flow. There's a lot of numbers in these guys. Okay? So our normal blood flow pattern is 750 mLs a minute, or 15 to 20% of our cardiac output. Your CPP, your cerebral perfusion pressure, and these, I did put the calculations on the bottom, how you determine, okay? So it's your MAP minus your ICP for the CPP. There will be no questions like this, but I would highly recommend that you do look at this, okay? Your CPP is calculated by subtracting the ICP from the MAP. 70 is generally accepted as optimal. When less than 60, it is compromised, and greater than 70 is increased intracranial pressure. Okay? And when it falls too low, the brain dies. Okay? There is no perfusion to the brain.
I was seeing some references that were saying a CPP 60 to 100
Where?
is normal.
Where?
I've seen it online, and I some of the nursing, some of these nurses that do the videos and stuff. So I don't know if I know I take some of that with a grain of salt, but I know we should always go back to the book.
Go back to your book.
Yeah, but I'm just saying that I didn't know why they would say that.
Most research is proven a little different, but it's not in textbook. There's always studies being performed, but it doesn't mean that it's accurate for every person. Each case is going to be different. Okay, but 70 is considered optimal. Okay? And I would never question you from anything from the internet. So, what's that old saying? Everything on the internet's not true, just about, right?
Yeah, it's just all these nurses that have their own YouTube channels and stuff.
Yeah. Well, I like you said, sometimes you gotta take that with a grain of salt too. That'd be like me getting on there making one about something,
And it depends on how old it is.
Right. Yeah, you're right. So, you get the MAP, and you'll hear a lot of this in nursing once you get out of the floor, okay? You're going to hear a lot about the mean arterial pressure, okay? And that's your diastolic blood pressure times 2, plus your systolic blood pressure divided by 3, okay? That I would want you to know for sure, how to calculate that, okay? And know that 70 is optimal. In this classroom, 70 is going to be optimal, okay? So our concept for us, normal or expected intracranial regulation versus impaired intracranial regulation. Okay? That is our concept. the little diagram of the normal state of ICP. You see nothing falling out. Compensated and decompensated. You see the levels. A lot of fluid shift change. A lot of change. So there, when you have in your skull, there is a fixed volume, and it doesn't like to change, right? It doesn't like to change. So we're going to look at the Monroe-Kelly doctrine. Our auto-reg adjusts the regional CSF in response to the brain's metabolic demands by changing the diameter of the cerebral blood vessels. Auto-reg allows the cerebral circulation to deliver a constant supply of blood despite wide fluctuations in the systemic blood pressure. It becomes impaired again when the MAP is below 70 or greater than 170. If ICP is greater than 40 or as a result of localized or global cerebral injury. Okay? So Monroe-Kelly is a hypothesis that states that the sum of intracranial volumes of blood, brain, and CSF and other components is constant. Okay? The skull is considered an enclosed and inelastic container. An increase in any of the volume of the intracranial components must be offset by a decrease of another one because there's not enough room to make change for the other, right? And this is what causes our increased intracranial pressure. Intracranial blood, especially in the venous, is considered and CSF are the two components whose volume can adapt most easily to accommodate an increase in the volume of the contents. Of these compensatory, once they're exhausted like these, they can't no longer compensate. Further increases in volume will keep going up, and that's what causes an increased intracranial pressure. Perfusion. One of our biggest concepts that we learn in nursing, right? If there is no perfusion, then it dies, right? So there must be a consistent supply of blood going to the brain. That's what delivers our oxygen and our nutrients to our brain. If there is an internal blockage, you can see hypertension, loss of vessel integrity, hydrocephalus. We're going to talk a little bit more about hydrocephalus in a little bit. That is an impaired reabsorption of the CSF or outflow of the venous blockage. Neurotransmission is optimal functioning of the brain, is dependent on the transmission of nerve impulses across the neuronal bypasses by the transmitters. Normal transmission requires fully functioning neurons, nerves, and neurotransmitters. So it kind of takes you into a little bit of your, I don't know if you've had one pro, but your neurotransmitters, chemistry, if you've ever had chemistry, it talks about a lot of those things. So some issues with these are drugs, toxins, and seizures. Okay. You can also have tumors, degenerative diseases, and inflammatory processes, meningitis. These processes vary, but the result is the same because it will disrupt the brain and its function and the regulation. Okay. A lot of definition. A lot of definition. Symptoms of intracranial pressure. Severe headache, not just a slight headache, it is a severe headache. Okay. Nausea, vomiting. Increased blood pressure. Decreased level of consciousness. Confusion goes along with your level of consciousness. They can have double vision, and our pupils do not respond. Right? Neurological changes. Neuroassessment. Again, we'll go through it again. Increased intracranial pressure, signs and symptoms. Changes in LOC. The eyes. Impaired eye movement. Pupillary changes, they don't react. Posturing. Changes in speech. They will have a headache. They can have seizures. Changes in vital signs. Cushing's triad. Cushing's triad is very important. Okay? They will have an increased systolic blood pressure, decreased pulse, and irregular respiratory pattern. Is that the same as shock? Vomiting. And because of peds, infants, they can have bulging fontanelles, cranial suture separation, increased head circumference, and a high-pitched cry. Miss Chandler likes to call your brain what? Lost wash. From this point on, you can refer to your brain as wash for the rest of your nursing. Your brain is wash. That's what she calls it. Okay. What can cause that intracranial pressure to change? Anything that increases your abdominal or thoracic pressure can increase pressure, which would be indirect, right? It's not a blood trauma, so we're going to go with that indirect increased intracranial pressure. You're vomiting, you're bearing down. ICP fluctuation can be influenced by your body temperature, CO2 and O2 levels, arterial and venous pressure, a widened pulse pressure, and if you are caring for a patient and the pulse starts to drop and the pulse pressure starts to widen and they have respiratory irregularities, call a rapid response. Not that they'll get there very soon. That they'll get there anytime soon. So, let's talk about blunt. Blunt force trauma. Motor vehicle accidents, that's always one thing we worry about when somebody has a motor vehicle accident, right? Brain injury. Okay? That's why when these people are taken out of a car, they are put in a cervical collar and they're transported on a board to the hospital. Right? Sports. Number one sport.
Professional.
Football. Football. High school kids. Little league to the NFL. You're going to see a lot of it in sports. Okay. Balls would be who?
Elderly.
Yes. Shaking baby. Shaking baby syndrome. I had one little boy a couple of semesters ago that had 4 subdural hematomas because he was shaken and he was born. So he had blunt force trauma. Okay.
You hear that as a lot of reasons for death, blunt force trauma.
Oh, yeah, we're going to talk about that. Yeah. Penetrating injuries. Hit somebody with a baseball bat. I hate to go to the murder side of it, but you know, or kids playing and hit somebody. You know, we'll go that route. When I was reading this last night, I kept thinking, God, I don't even want to talk about that. Like, it's murder. Intracranial pathologies. Bleed, which you see likely with what? How about some of the medicines that we take? How about some of the medicines that we put these people on? Okay. I told you all the story about the headache and she gave him morphine for the headache, remember, and he had a bleed. He was elderly, he had been on Coumadin. Right? Cerebral vascular accident, CVA. Meningitis. Tumors. Those are all indirect. Again, increased ICP. There must be an increase in the tissue, blood, or CSF in the brain. Here we go to, we do a lot of these now. Meningitis, all kinds of things. We do everything. If you have signs and symptoms of increased ICP, you would not do the lumbar puncture. Never would you do a lumbar puncture. Understood? That's why we check those kids out really, really good because they do a lot of them now, a lot of lumbar punctures now with meningitis. Reactions of brain to injury. Primary injury occurs at the time, right? When it happens. If it's open, when the skull is fractured or when penetrating objects pierce the brain. Closed, the integrity of the skull is not compromised. The outside's not compromised, right? Bruising of the brain, contusion at the site of impact. Could be from a fall. Contracoup is bruising of the brain on opposite side of the impact. Why do you think that happens?
Like, if you suddenly stop and your like head jerk back,
Like you hit it somewhere and then it shifts the the fluid inside the brain, and then it goes somewhere else and like to the front and makes a bruise because it hit it that hard.
So would you see that in like NBAs, like going forward and the bell catching you?
Well, you have to get your hand. But that's conjugate bruising of the brain on the opposite side of the impact. If they hit their head on the back, they come with a bruise on the top or the front, right? It's because that sudden shift to the front. A secondary injury results from physiologic, vascular, and biochemical events that are an extension of the primary injury. Examples of secondary: hypotension, hypoxia, intracranial hypertension, and cerebral edema. You're going to see a lot of hypoxia and hypertension in anybody who has intracranial because of the lack of perfusion. Hypotension may be itself related to the shock of the incident. And you can have reduced perfusion because of a clot in the brain. Hypoxia, then it can cascade to lead to respiratory failure, asphyxiation, loss of airway, and of course impaired ventilation. These people are really critical. I think you can just picture that. They are very, very critical. Increased ICP is the leading cause of death in anybody who has a head trauma. Sometimes it's not recognizing the signs and symptoms fast enough. Very important thing that you will need to know this semester and next semester: if you have a patient with TBI and on a vent and they become agitated, give them Precedex. It is a sedative, and it does give you the formula. Precedex has a short half-life, and it's metabolized in the liver. Remember Precedex this semester, next semester, for the rest of your life when you take your boards. Precedex. TBI classifications: mild concussion. We have a lot of people who have concussions, right? They lose consciousness for less than 30 minutes. They can become disoriented or foggy. They'll have a light sensitivity, a little bit of loss of memory immediately after the event, and they may have some neurological deficits. Anybody who's in an MBA, they try not to let them go to sleep, or I'm sure you all have heard this. They try not to let them go to sleep because they want to make sure they didn't have a concussion, so they don't fall asleep, and then you don't recognize the signs and symptoms of it. Okay. Moderate, your LOC, loss of consciousness, is 30 minutes to 6 hours. The Glasgow Coma Scale will be between 9 and 12. And after adding up the Glasgow Coma Scale, if it's 12, they will be confused and will need frequent orientation. Severe is defined as 3 to 8. that requires intracranial pressure management. This is the time when you have to explain to families about personality and behavior changes, especially for children, parents, teenager football players. I've seen it. These people, when they have severe brain injuries, they have to have long-term support. It's not something that they can get over very easily. Okay, they usually have to go to rehabilitation, and they need multiple support systems. Sure, you all heard this, but if you have a head injury and you see clear fluid coming from the nose or ears, we test the C for CSF, the cerebral spinal fluid, and that is called the halo sign. Positive halo means that they are leaking the CSF. This puts them at a high risk for infection.
I heard of a story of a girl who, her nose just kept running. The doctor said she just got allergy. She kept going and she kept pursuing it and found out it was fluid from the brain.
ICP monitoring. Again, infection control. Stress hand washing. Fever is never a good sign. Never a good sign with anybody who's had a head injury. Brain hemorrhage. In between your epidural and your skull, see that blood flow in there? Subdural hematoma is going to be inside, but you can have an extradural hematoma also. Traumatic brain hemorrhage. In the epidural, it results from arterial bleeding into space between the dura and inner skull, like we saw on the left side. Subdural is venous bleeding into the space beneath the dura and above the rhabdoid. It can be slow, and you may not see the effects of this for 2 to 3 days, basically. Intracerebral is within the brain tissue. And if it ever is in the brainstem, it is a very poor prognosis. All hematomas are life-threatening. There is no one that's any better than any other, okay? Because they take up the space, okay? And they are surrounded by edema. Hematomas are full of blood, and it forms edema. Okay? So it doesn't matter where they're at in the brain, they're all dangerous. All right, when we're assessing these people, LOC is our highest priority. That will be our first sign of deterioration in these people. History, if you can get it, is something you would want to ask. You want to worry about their ABCs, airway, breathing, circulation. Spinal precautions, again, because if they have a head trauma, They are treated as if they have a spinal cord injury until they are proven not to have one. That's why they are transported with a cervical collar and a board to the hospital. Okay? Vital signs. You can have hypovolemic shock. Cushing's triad is late signs and symptoms of ICP. Okay? The hypertension, the widened pulse pressure, and bradycardia. Again, pulse pressure difference in systolic and diastolic blood pressure. Cushing's triad is a late sign, and it usually is not a good outcome. In your physical assessment with these people, you want to use the Glasgow Coma scale. You want to assess their LOC every time. Every intervention you do with these people, you want to assess their LOC and their pupils. Cushing's triad. 3 primary signs that often indicate increased intracranial pressure. Increased systolic blood pressure, decreased pulse, decreased respiration. Opposite of shock, because it's decreased blood pressure, increased pulse, and increased respiration, right? I cannot stress to you how important Cushing's triad is. It is considered a classic, but very late sign of increased ICP. Consists of severe hypertension, a widened pulse pressure. That's the increasing difference between your systolic and diastolic blood pressure if you don't know that, okay? Like it would be like 200 over 80, okay? Bradycardia. And the triad itself, when this happens, usually indicates imminent death. You all ever assess the patient for dilated pupils? You ever assess their pupils and like see how they react? I'm sure you did an assessment. I don't know if you all did assessments on each other, or I'm not sure how they teach you to do assessments, you know, in class. When they become non-responsive, it's indicative of brainstem dysfunction, okay? And that occurs with the pons in the brain. So any change in level of consciousness on any patient, you assess the pupils. Okay? We have a lot of people who fall in the hospital, right? So you would want to assess them every time you go in there. At least assess their pupils. Sometimes you don't even know if they hit their head or not. Because you don't always know if they hit their head when they fall. You may not even be in that room. You know what I mean? You might be in the other room or anything, and they could wake up immediately. You know what I mean? But that doesn't mean that they didn't do some damage. So assessment is of the utmost importance with these people. Is she here? Is she here?
Probably by now, yes.
I'm going to give you all 5 minutes so that way I can let her take some class. Because we don't allow late admission, but I will let her. So I'm going to give you go ahead and take 10. And and we'll let her come in.
She might be in the
Here's your little snacky food.
snacky snack.
Wait, I have a computer.